I teamed up with Susie a while back, and we've been doing a lot of work with blood flow restriction. We think it's a nice new modality. Susie's the expert in this field, and so I'm going to let her talk a lot about the physiology and background of this, and then I'll throw in some practical application and how I've been using blood flow restriction and give you some different diagnoses that we've been using it with. And then we're here to help make it a little more comfortable for you folks, and we'll chat about all of that. So as we go along, if you have any questions, let's go ahead and leave them in the chat. I'll try to answer some of those while Susie's chatting and talking. And we'll leave some time at the end for questions also. So feel free to ask as we go, and we'll spend some time at the end answering some questions too. So Susie, take it away.
All right, awesome. Well, it's nice to see you all virtually, and Paul and I are very excited to give this somewhat short and condensed webinar on kind of a brief, good overview of the BFR modality. While we're here, I'm going to start sharing my screen because I have a PowerPoint for you to follow along with me. So we're going to do that first. And can everyone see right here? Are we good? Yes. Okay. Yep. Awesome. Excellent. All right, here we go. So we are going to slideshow. We're going to start from the beginning. All right. So obviously, we're going to do just a quick introduction of myself and a little bit of background from where I am. Many of you probably know Paul and his background, but those of you who don't, I'm going to give him a second just now to kind of reiterate kind of his background and how he got involved with me with blood flow restriction training. Let's see, a quick overview is I did my undergrad degree concentrating in sports medicine. Then I went on and got a master's and PhD exercise physiology. About 10 years ago, I got really interested in blood flow restriction training by reading all of the Katsu articles from Japan. So I ended up doing my dissertation on blood flow restriction training. And ever since then, for the last 8 or 9 years or so, after that, I've been going around using education. I'm a practitioner with it, using multiple case studies. I've guest spoke at Brigham and Women's Hospital with the Harvard Med students, as well as the orthopedic staff there. A lot of colleges, a lot of universities, and I do obviously a lot of certifications for physical therapists, athletic trainers, OTs, PTA, strength and conditioning coaches, you name it. I've worked with a number of different devices that are out there. A lot of certifications, instructors, all of that. That's kind of me in a nutshell. I won't keep going on about that, but I'm a pretty big practitioner within this field. I know this modality inside and out, and I've used it with a lot of different populations in clinical studies and basic client studies, all different various populations. I'm the director of the Division of Exercise Science at American International College in Springfield, Massachusetts. I also teach in the graduate physical therapy department. I teach their gross anatomy labs as well as their advanced exercise physiology class. So that's me in a nutshell before I get going. So I'm going to kick it to Paul if he wants to do a brief introduction, and then I'll get into the modality a little bit.
Yeah, so I got connected with Susie through Dr. Christian Latterman. He is a condylar transplant specialist down in Boston and head of the orthopedic department down there. And so I had a patient who had a retropatellar chondral lesion, and just a very, very challenging case. And he had done a reconstruction on her, basically took the bad piece out, put a new plug in, was non-weight bearing for a long time, just had a very difficult time trying to get back into weight bearing and whatnot. So her doctor, we did a telemed with him, and he's like, hey, have you ever considered blood flow restriction training? And I said, I'd really just heard about it, but really didn't have a lot of experience about it. I was kind of a skeptic. And so he connected me with Susie. And I went down to Springfield, Mass. And underwent a certification training with her, and went in a skeptic and kind of uncomfortable. I like to be confident with the stuff that I do. And when I came out of there, I just totally felt comfortable, learned a ton, and have been using blood flow restriction ever since for a multitude of orthopedic conditions. Actually used it again this morning on somebody, and I'll be going through the specifics of that. Other than that, I'm the Vice President of Clinical Operations at County Physical Therapy. I am a brand ambassador for Mainly Technology Group, and I've been working with Susie now for almost a year on different projects. I own Maine Orthopedic Seminars, and I give live courses, and I also own Ortho Eval Pal and have a podcast show and do online coaching, and have a growing YouTube channel that just kind of, I have content out there to help people feel more comfortable with orthopedic conditions. So that is me in a nutshell, and I'll keep all the rest of my extracurriculars out of it and just keep what's relevant for today. So Susie, I'll let you take over again.
Awesome. Sounds great. All right. So now we're going to head into today, the whole point of today's webinar. Our agenda is I'm going to really go over a little bit of a definition of what is blood flow restriction training, a brief history of the modality, an overview of the mechanisms, efficacy, safety, some proper education points. And if we have time, hopefully I do have some bands here, some different systems that maybe I'd be able to do a demonstration for you all. Before I get going, I would like to say, Paul and I will include our contact information within the chat, as well as it is on the PowerPoint at the end of this. Please feel free to get in contact with us. I'm very open to talking about questions afterwards. I know our time is very limited today, so we'd love to keep open communication with anyone who has come to this webinar and answer any questions you may have. Or if anyone is interested in a bunch of research articles, I'm happy to share those as well, as I have, a plethora of those for the most part for you to reference on a number of different populations and conditions and injuries and so forth. So with that being said, we're going to head on into what is blood flow restriction training. I have to preface this whole thing by saying this is probably the hardest thing for me to do, is to kind of sum this up in 40 minutes or so with Paul and I. I'm so used to giving this in class. I teach it to the graduate PT students within class. We have a whole class, a whole lab with it. Used to the certifications, used to guest lectures that are a little bit longer and a lot more hands-on. So trying to give you a really good summary within 40 minutes is definitely going to be the most challenge for me, but we're going to do our best, and hopefully you will get a really much better understanding of what it is, how it works, and the importance of proper education on this modality. So what is the goal of blood flow restriction training? You might see a lot of stuff when you go out into the internet, and the internet's a double-edged sword out there, right? There's a lot of good stuff, and then there's a lot of not good stuff. So hopefully I can help answer some of those questions today. The goal of blood flow restriction training is to allow some arterial blood flow into the muscles, but to restrict venous outflow. And you do so by the restriction of a band or a cuff placed proximally on the limbs. Really only two places you're going to put this: on the upper arms, right underneath where the deltoid inserts, as well as the upper thighs on the lower extremities. You don't want to occlude the blood flow to a limb or group of muscles. There's a good amount of research out there that how pure occlusion training can still show a lot of benefits, but when we're talking to apply it to a wide variety of populations, you really don't want to occlude for safety reasons. And again, that is a part of the educational course we give on safety and efficacy of the modality. So this is what the whole goal is to do, is you want to place it proximally on the limbs, and you want to exercise at very low loads and low intensity. Now, low loads, meaning maybe 20 to 30% of your 1 rep max you might see in the literature, but might even be body weight, or really no load, no weight that you're holding at all. It's just really low loads, low intensity, but again, you want to elicit, we'll get into the protocol in a little bit, high repetitions. Okay. However, even though we're exercising at very low loads, we are eliciting very similar physiological responses as if we were exercising them ourselves or our patient or client at a high intensity, estimated between 70 to 85% of their 1 rep max, having very similar biochemistry, metabolic, as well as musculoskeletal adaptations as if someone was exercising at 70 to 85% of their 1 rep max. So for example, very high intense exercise. I first read that when I read that first Katsu article from Japan, and I had to reread it 3 times. And I said, there's no way that these results are getting this. Then as I dove, I pretty much got every article I could find and to read on the physiology of the modality. And then it just completely makes sense when you learn about the mechanisms. But a quick history of BFR, actually, even though it seems to be new and upcoming right now, it actually has been around for quite some time. And Dr. Sato out in Japan has actually developed this, or came up with this whole idea actually back in the 1960s, but has kept it pretty close knit within the Japanese community for about a few decades for the most part. So anyway, in the 60s, when he was about 18 years old, he was at a funeral and sat in this, what's called a Cezar position here, and for multiple hours at a time. He was a bodybuilder, he engaged in high intense strength training. So he knew what it felt like when he engaged in one of those exercise regimens. When he rose, he said he felt similar to how they felt when he had done an exhaustive strength training workout. So he thought to himself, why is that so? I've literally just been sitting here. I must have restricted my blood flow to my limbs at some point in time for this. So he kind of had that thought going over the next couple of years and seeing what happened. Well, a few years later, he got into an alpine skiing accident, had a pretty big knee injury, and kind of broke his ankle, and and all of that. He ended up actually getting a full length leg cast put on him, and then he decided to put his hypothesis to use. He took belts around his upper thigh and kind of just altered different pressures. Obviously, we didn't know the pressure, but kind of cut off his blood supply or altered his blood supply to the affected limb on his upper thigh. And he added in isometric leg exercises while in that leg cast. Usually, most of you know, and most of you who don't know, when you're in a long leg length cast, what happens is you have to get it replaced every 6 weeks or so, just due to the immense amount of atrophy that occurs. So you have to go get a new one put on. But at that time, the doctors found that he had little to no atrophy at all underneath that once they took the cast off, and his ankle injury was completely healed. He felt fine. He walked away that day. So he said, okay, well, whatever I did by altering those blood flow patterns, I obviously did something to save my muscle mass. So then, boom, we're just going to scoot through. I'm not going to go into this too much and more. During an education course, we kind of dive in a little bit more of the nuances of this, but then for the next decades, experimented with judo belts, bicycle inner tubes, ACE bandages, you name it, and experimented on himself and his personal training partners and clients who allowed him to with this type of training. So we're kind of fast forwarding much more, much further on down the line, and eventually these Katsu masters, which were kind of invented and kind of perfected over the years. A large Katsu master is very expensive, and they were, pretty unattainable to get. About 10 years ago, when I was interested in doing blood flow restriction, this is the best device that was on the market and the most reputable, of course, under Dr. Sato. So I had messaged the Katsu training system out in Japan. I said, would you be willing to train me, or would I be able to use it? They said, of course, you got to come to Japan, become a Katsu master, and then you can purchase our $5,000 or $6,000 machine to do your dissertation study. I did not have that kind of funding, so I had to use the next best thing at that point in time, about 7-8 years ago, which was blood pressure cuffs at the time. All right, but now it's becoming much bigger, and then sort of the Western side of the world starting to hear about it, and then they had to pretty much redo what he did with ACE bandages and bicycle inner tubes and all of these things. And now you'll see a multitude of devices that are out there, and you'll see a bunch of different things are out there. I could put up many more pictures too. And a part of that education course, but Paul and I go through, or that I always discuss with individuals, and which isn't the point of today, it's really just to get to know the modality, is we really dive into the different devices. I've used all different devices, on a practical standpoint and a clinical case standpoint, as well as know the material and the makeup and the safety and efficacy of each. So we do go through that because it is really important as a practitioner to be able to do it safely and most effectively to a wide variety of populations. Okay. So to review our size order principle here, the professor and me always needs to review a concept at the beginning to make sure it connects with the later concept for you to understand. So we know that a size order principle, in order for us to activate our type 2B muscle fibers, our higher order motor units, we need to exercise at a high intensity. So motor units are recruited from smallest to largest, right? And if we remember what a definition of a motor unit is, it's one alpha motor neuron and all the muscle fibers it innervates. And the more of those that we activate, the more musculature involvement that we have. And the more we chronically train like that, then boom, we get enhanced benefits, okay? However, if we have low loads, low intensities, we're really just activating our type 1 muscle fibers. They're the easiest to activate. They got the smallest alpha motor neuron along with them. So we're really not activating these type 2B muscle fibers. Now, if you remember back to XPhys or basic XPhys, in order for our basic strength and conditioning concepts, the muscle fibers that respond most to strength and hypertrophy are our type 2B. So how can we activate these type 2B muscle fibers safely and effectively? Now, for the most part, we need to increase force production, which means enhance load to activate these higher order motor units. Now, the whole point of the talk today is not everyone can lift heavy loads, especially in the rehabilitation, post-surgical population, our aging population. And then some people just purely don't want to lift 80% of their 1 rep max sometimes, right? So how can we get those type 2B muscle fibers to activate without lifting heavy loads? And BFR is the answer with altering hemodynamic patterns. Okay, so that's just a quick review here, right? Our type 1 muscle fibers love oxygen. That's the key point right here. For their energy systems to go through aerobic metabolism, it loves oxygen, right? Type 2A, somewhat our middle of our road fibers, those are mixed. And then our type 2B or our type 2X fibers are those muscles that we use for heavy weightlifting, sprinting, high intense exercise. However, they are the ones that respond most to hypertrophy, strength, neural hormonal responses within the body, all of that. So we got to activate these really to see an improvement and a good amount of improvement in strength, hypertrophy, muscular endurance, all of that. Okay, so that's a quick review here. And I just wanted to remind you that these type 1 muscle fibers who are activated first love oxygen, right? Okay. And then right here with chronic training, you know, we have 1 muscle fiber here, we have 2 different forms of hypertrophy. Sarcoplasmic or transient hypertrophy is just where blood or water is trapped within the muscle cell. So if you get, for example, a pump, if you exercise, that immediate hypertrophy that you see is really because of water. It's not, you're not gaining, your muscles aren't magically growing before your eyes. It's really just due to that water. But with chronic training, we enhance these myofilaments with protein synthesis, which is actin myosin, which is going to enhance cross-bridge cycling and therefore strength in the end. And this is what we really want to attain there. Okay, so how does this relate to BFR? How does that heavy resistance exercise really come into play with just altering hemodynamic patterns? Now, we're not going to go into all of these mechanisms because it would take definitely a very long time, but mechanisms that are out there that I can share articles with and have heavy reviews on are, we talk about fiber recruitment, the various metabolic responses, cell swelling responses, our anabolic hormone response, and then of course our mTOR pathway activation, which enhances protein synthesis. Okay, so I'm going to give you a quick overview of that. So let's talk a little bit about the physiology of BFR. When you are restricting to a group of muscles, it's going to promote pooling in our capacitance vessels. So the restricted of blood flow to the area, we're getting less blood and nutrients to the muscle cells, and we are diminishing the clearance of waste. Makes sense, right? We're diminishing blood flow coming to the area, we're diminishing oxygen and nutrients coming to the muscle cell, as well as we're diminishing the ability to clear it efficiently. So this is creating an ischemic or a hypoxic environment within the muscle cell. So again, let's go back to that size order principle. Our type 1 muscle fibers love oxygen to work off of for our energy systems. However, with restricting blood to the muscle fibers, less oxygen is getting to the muscle fibers. So type 1s, even though they're activated first, they're going to fatigue extremely quickly because they love oxygen to run off of. So those are going to, what I always say, they're going to poop out first. Even though we're going to activate them, they're going to poop down and poop off and drop off. So if we keep exercising, what has to activate next? What muscle fibers have to be called into next? Those are our type 2A and type 2B muscle fibers. So even though, so we're pretty much tricking our body into thinking we're performing high explosive exercise, but all we're doing is altering these hemodynamic patterns, diminishing oxygen to the muscle, so then we can actually activate those type 2B muscle fibers much quicker in the exercise program with very low loads. What do our type 2B muscle fibers work off of? Anaerobic metabolism, media energy systems, as well as our anaerobic glycolysis system. And I'd like to just note out before we head into the other, how it relates to a hormonal response. When you go through anaerobic pathways very quickly, two of the biggest byproducts are hydrogen and lactate, right? And hydrogen is going to decrease the pH within the muscle cell, within the blood, and enhance an acidity. And that's a key player later on with regards to our growth hormone and IGF-1 response there. So in order for us to keep exercising at that same intensity, more motor units must be recruited. So we will keep recruiting those motor units until we have activated all of our muscle fibers within that muscle or muscle belly or group of muscles. So we've done that kind of almost in a sneaky way by altering blood flow patterns. We have actually activated all the muscles that we want to in this exercise program, except we are lifting very low loads. So to give you a visual right here, look, this is traditional resistance exercising. We have this guy, this is very, very low weight for him. Let's just say he's warming up. He's really only working his type 1 muscle fibers because it's too light for him. You know, it's not heavy enough for him with that size order principle to activate those type 2Bs. Now we're going to add a little weight on. He's going to activate the next size up muscle unit here, and then we're going to double that weight. So he's lifting probably about 75–85% of his 1 rep max here. Now we have successfully attained activating those type 2B muscle fibers, right? That's traditional exercise. Now we go over here with BFR. We're only going to stay here with the really light load that he has right here. So he's going to, after a bunch of reps, still only be activating those type 1s, but as blood flow is diminished to those muscle fibers, we're diminishing the oxygen, what those type 1s love. So as he keeps squatting up and down, what has to be activated next? His type 2As, and then he's going to keep exercising because we're not clearing waste enough. We are the acidity within the muscle fibers, it's causing a decrease in the amount of actin myosin cross bridge cycling in these fibers. So what has to activate next are type 2Bs. So then, but he's still lifting just this. So here, once we get into the protocol, it's high amount of reps with low weights, but again, he's going to get the same benefit as if he was lifting over here. Does sound too good to be true, but we go more in depth. Again, I'm happy to answer any questions regarding mechanism 2 later on. So once you release the bands, release anything, you get what's called reactive hyperemia, similar to when you get your blood work taken, but again, we're not including here. We have a dramatic increase of blood flow to the area post-exercise, so it enhances cell swelling, which is a mechanism that enhances protein synthesis, and a large surge of blood comes through, drags all the good hormones, amino acids into the cell. So that's what happens as well with cell swelling. Now, a quick little note here before we get into the protocol, how metabolic stress and hormones play a role. So after we've activated those type 2B muscle fibers successfully, we're going through the energy system that produces a lot of lactate, a lot of hydrogen. So we have an area of decreased pH. And those hydrogen ions and those lactate ions actually activate what's called our type 3, type 4 afferent muscle fibers. And that signal sends to the brain saying, hey, we're in trouble here, we need some help. So we have an immediate release of growth hormone, surges into the body from our anterior pituitary gland. So we'll have a huge, almost immediate surge of growth hormone. Then as that circulates in the body, that works hand in hand with our other anabolic hormone, IGF-1. So together, growth hormone, IGF-1 enhance amino acid transport within the cell, enhances that mTOR pathway, which increases protein synthesis, and boom, that's really what we want to increase muscle fiber size with hypertrophy and really increase strength. And that's the whole point here, right? So that's kind of a quick nutshell of how that works. So we really want to be under a high amounts of metabolic stress within that muscle fiber, within those muscles that are working, because we're going to have a bigger neural hormonal response, the bigger metabolic response that we have. Okay, so you might ask, okay, well, what about the protocol? There's a bunch of different things out there. That is correct. So depending on the patient, the client, what your goal is, we could talk forever on protocol. But kind of rule of thumb here with BFR is you'll see anywhere from you want to have someone do maybe 3 to 5 sets per exercise. You can either have them exercise per set till failure before they take a break, or I like to call it the rule of 30, where it's 3 sets of 30, and 30 seconds rest in between. So very quick rest periods, but the whole point here is we want to build up that metabolic waste and clear waste. We want to lessen the clearing of waste because, again, we want to activate all those muscle fibers and get the biggest neural hormonal response there. So high reps, low rest periods, and then you're going to get the biggest response. You'll see out there anywhere from 20 to 50% of your 1 rep max. There's no added benefit to lifting heavier weights. I get this all the time from students. Well, what if I do BFR and still lift at 85% of my 1 rep max? Can I get double the pump, double the response? Well, the answer here is it's going to that's kind of counterintuitive. What do heavier weights do that BFR doesn't do is induces high amounts of mechanical damage. So a lot of those micro tears where a lot of people are getting a lot of that delayed onset muscle soreness, with BFR, you don't nearly have as much mechanical damage. And that's the whole point, because then you can do BFR much more frequently throughout the week and recover quicker, and then do another BFR workout, activating those type 2B muscle fibers. Now, normally you can't do that with a heavy lifting routine. If you're squatting 85% of your 1 rep max, you're doing that once a week. You have to give your body that time to rest, recover due to that inflammatory response. All right, so there's really no added benefit in adding heavy weights. You want to lift heavy weights for traditional resistance exercise, don't do BFR with it. At that point, you might just be a little bit too fatigued and you don't want to put yourself at an increased risk of injury, let's say dropping a weight on your hand or your foot or something like that. So there's really actually no added physiological benefit to adding heavier weights to that. So where can we apply this? We can apply this in rehabilitation settings, strength and conditioning settings, general fitness, and the aging population, and just enhanced functional capacity overall, right? So we've seen it in a lot of different. This was a patient who had a spinal fracture. We have an aging population who does this on purposes for enhancing bone mineral density. And all of that. Then we have general fitness. This is a CERT course here. Obviously, you could see pre-COVID because no one is in masks. All right, so a couple studies before I kick it to Paul, and then he can talk about all the wonderful stuff he's been doing up in his clinics with BFR after we've connected. So a good study to quickly talk about based off of a musculoskeletal standpoint would be this post-ACL reconstruction surgery study. And I'm going to briefly just kind of really run down real quick. They used 8 experimental individuals and 8 control individuals, all post ACL reconstruction surgery. Now, the control group didn't do anything. All they did for 2 weeks, they didn't do anything, no exercise stimulus. They just got an MRI at 3 days post-surgery and then 14 days post-surgery. The experimental group, every day for 14 days after day 3, they used a blood pressure cuff and used a restrictive stimulus for about 5 minutes on that thigh. That was affected, 3 minutes off, 5 minutes on, 3 minutes off, 5 sets per session, and they did that twice a day. So they were under a restriction about 25 minutes total in the morning, 25 minutes later in the day, right? And again, no exercise stimulus here. They were actually just sitting there, no isometric exercises or anything. They were just altering hemodynamic patterns, sitting still. So here's the results here. These are our extensors, all of our thigh muscles. This is the decreased percentage in cross-sectional area from the MRIs. Now, with the control group who did nothing, no stimulus, no BFR stimulus, let's look at the extensors because we know the quads take pretty much almost the biggest hit with post-ACL reconstruction surgery. You see here, average over about 21-22% loss of quads just in 2 weeks' time, just because of disuse post-surgery. We got one person out here that almost lost probably about 23-24%. Now let's compare it to the experimental group. Now, even though they're not exercising, they're non-weight bearing at this point in time, you're still going to have some atrophy. But look at the atrophy compared. They're only about an average of 9%. So they were able to save half of their quads compared to the experimental group in 2 weeks' time. To me, that's a pretty big deal to save that amount of muscle mass within 2 weeks' time just by altering hemodynamic patterns, reading a book, doing whatever they wanted to. Losing almost a quarter amount of your quads is pretty intense. So this was a great study to show how much muscle mass can be preserved by doing this different types of alteration of hemodynamics there. So I just like to pontificate out loud with my students all the time. I say, okay, less atrophy. Does this mean less decrement in strength loss? Could this diminish our rehabilitation times with our patients and our clients? Can we get athletes back to competition faster? Can we then also enhance or maintain effective cross-bridge cycling? We're saving those actin myosin filaments, so we don't have to work so hard to keep building those back up. Did we save half of them? Those are just some things I'd like people to think about. So heading into my next study, we're going to just talk about we talk a lot about musculoskeletal orthopedic stuff here. However, I would like to just talk quickly about, I get these questions a lot. Well, what about cardiovascular? Is there any cardiovascular benefits to this as well? Well, let's talk quickly about this hypertensive patient study. There was 23 hypertensive women with a clinical diagnosis of high blood pressure, and they were on medication. They had 3 groups. There was a high intensity resistance exercise group with no BFR, a low intensity with BFR group, and then of course a no exercise group. There was 2 experimental groups trained twice a week, only twice a week for 8 weeks. And then the BFR group exercised 70% of their resting systolic blood pressure. Okay. So here, what always makes me laugh with this study is that they chose to do wrist flexion exercises. So they did wrist flexion exercises, the BFR group, 30% of their 1 rep max. High intensity group, we're using wrist flexion exercises at 80% of their 1 rep max with no restriction. They did 3 sets of 30, 3 sets and 30 seconds of rest in between sets. So let's see the results here, which is the biggest point. After only 8 weeks. Control group, this is the percent change in blood pressure. We have systolic, diastolic, and mean arterial pressure here. Control group, not much changed. Nothing really happened, maybe a slight increase in systolic. Now, our heavy resistance exercise group that was exercising at 80% of their 1 rep max with no BFR stayed the same, pretty much around no change, maybe a slight decrease in systolic. Now let's look here with the BFR group. They had over a 10% natural decrease in systolic blood pressure with BFR. About a 10% decrease in diastolic pressure, same with mean arterial pressure. Now, as an exercise physiologist standpoint, as a healthcare professional, I say, hey, being able to lower your blood pressure naturally or from some sort of exercise stimulus is huge, right? Does that potentially mean, let's pontificate again, maybe less into medication, maybe potentially ever getting off medication, all of that. So this is a huge study with regards to blood pressure. Now, someone asked, well, why did that happen? What the researchers hypothesized and need to look into a little bit more is that BFR, due to that ischemic and hypoxic environment, may enhance vagal tone response, which obviously can decrease heart rate, which then leads to a decrease in blood pressure. There also may be an exercise pressor reflex may be involved with BFR within the heart as well, within that mechanism that can help decrease heart rate and decrease overall blood pressure. So that was also a neat study that I like to talk about. So what are we doing current practice-wise? This was a post-total knee surgery, post-op total knee that I did a case study with, and I was working in conjunction with, he went to physical therapy twice a week and then did BFR twice a week, not only on the legs, but on the arms. And that's a key point too. You want to be able to use BFR on multiple limbs because it's, again, a systemic response. You don't need to just localize it to one area. Now, he actually rehabbed in almost half the time that he was expected. The owner of the PT clinics and a couple of the PTs that were working with him said, hey, well, we're confused at how he was advancing so quickly from where he was. And he said, oh, I'm doing this, case study too with BFR and all this, which prompted the owner to give me a call and said, you got to come here and talk to us about this and see what's going on. So I did and gave them a whole certification training. And now they're completely employing it in their clinics, which has been great since they saw what great results he had working in conjunction with the PT there. And then I used other studies such as, it's tibial osteotomy, all of these things. We could keep going on and on all day. But right now I would love to kick it to Paul and have him talk about all the wonderful things he's been doing with his patients up in Maine.
Yeah, so, first thing that I want to mention is that, we're going to go from the technical to the practical now. And one of the things about BFR is it's very humbling. Until you use it and try it, you really don't understand what I mean by that. And I recently had a patient who was a total knee replacement and, former state trooper, exercises every day, wants to push hard and he doesn't really listen to you. He just wants to push and push and push and do more. And so we said, well, obviously, you know, 3 weeks after a total knee replacement, you're not going to be squatting 300 pounds. That's not a healthy thing to do to that muscle that was just surgically, you know, cut into, and that knee being fixed and whatnot. So we said, why don't we just put a low load on you with lots of repetitions and lightweight, and we're going to do it with BFR. And completely burnt him out with about 4 different exercises. And he was sweating. Not only does this work on the muscular system, but your cardio is going to work a lot more. So you're pretty fatigued when you're done doing BFR. So just a couple examples, you know, obviously there's some people you can't push hard right away. You know, your meniscus repairs that may be non-weight bearing for a while, or like we have here a post-op ACLR, and so right here we're just doing light modified knee extensions, really lightweight, but doing 30 repetitions. And I kid you not, when he was done his 3 sets of 30 on each side, this kid was screaming. Okay, and he had very, very little weight going there. Now, the next picture we have is an olecranon avulsion. So this young man tore his olecranon off using his tricep, pushing really hard. And so basically we gave him a period of rest. And then obviously we can't do things like push-ups. We can't do heavy skull crushers and things like that. So we give him a big 1 pound pink weight here, put him on BFR, and he could not complete a set of 30 repetitions because he just fatigued out. And that was the objective. And we really moved this guy ahead really quickly. So we were not putting the olecranon, you know, fracture, you know, at jeopardy by using the lightweight, but just doing lots of repetitions. So Susie, if you could hit the next one, that'd be great. This young lady had a patellochondral transplant. This was Dr. Latterman's patient. She was rehabbing with us for about 4 months and really stagnant, and had a difficult time just kind of getting over the hump. And we had done a lot of modifications with our treatments. The only one thing we did different was added BFR to her program. So lots of repetitions, and with her being young and healthy and willing to work hard at this stage, we did it on all 4 limbs, which was pretty cool because you could do some upper and lower all at the same time. So getting more of a metabolic release at, you know, and working with not so much load, because patellofemoral dysfunction like PFC and lateral patella compression, those things, we want a strong quad, we want a big quad, and they make a huge difference. But it's hard to get from point A to point B by using heavy weights and heavy loads because it just causes them too much pain. So with her, within 2 weeks of using BFR, had a significant acceleration in her ability to start running again and jumping and squatting and doing all those activities with a better knee posture. Her confidence level just shot through the roof, and everything just kind of accelerated at that point just with that modification. Here's a gentleman who tore his distal biceps tendon and he had it repaired. And so of course we can't do a lot of, you know, load with, you know, elbow flexion and supination. But we do want to get that muscle bigger and stronger, and we wanted to do it faster. So what we did is we took a 2 pound cane here, and this was not long after surgery. I want to say maybe 3 weeks after surgery, and we started activating his bicep with lots of repetitions and low weight. And to be totally honest with you, after this first visit of doing BFR with him, he came to me and he said, "This is the best my arm has felt ever since I had surgery. It's like this one thing made a huge difference." And so we continued using it. So not only are we doing it with bicep curls, but we're also doing tricep presses. We're doing wrist flexion, wrist extension. We're doing internal and external rotation of the shoulder. So we don't just get the effect below the band, but we're getting a systemic effect also. So now using 2 bands with this gentleman. Here is a lady with a severe proximal tibial plateau fracture. And as you can see on the shuttle, we have 2 bands going there. That's super, super light. She had some weight-bearing limitations, lots of weight-bearing limitations. And so we needed this quad to get bigger, faster. And so we put her on BFR, did lots of low weight, high repetition exercises, which was extremely fatiguing, but helped with regaining that quad strength and that quad function. Just this morning, I had a gentleman with a tennis elbow. And so we're doing a lot of high repetition, low weight, wrist exercises, arm exercises. We just had a young lady with lateral patella compression syndrome. I say young lady, 60 years old, a little bit older than me. And, you know, we could not push her. We did 3 or 4 visits, and everything we did, like the shuttle, squats, knee extension exercise, anything we did to try to activate the quad, but not agitate the patellofemoral joint, wasn't working. So we started some blood flow restriction. We've done 3 visits. She says, I've been pain-free. I went backcountry skiing recently. She said, I had no pain with that. And 2 weeks ago, I was having pain doing that. So exactly the same activity, but no more discomfort. So, you know, we're getting that quad activation, better patella tracking. So it's really a nice little bridge to get from point A to point B without overloading and overstressing the tissues. And, you know, very safe to use, very easy to use. Some systems out there are very complicated. And when I went with Susie and I had a chance to play with the other systems that she had there, it's just, you know, you really want to pick your system that is easy to use. You can do multiple joints and whatnot. But as far as practical use, I'm almost using BFRT every day at this point. And it's been really one of those modalities, like, you know, when you do ultrasound now, you know, it costs $2,000, $3,000, $4,000, $5,000 for an ultrasound unit, and you bill out ultrasound for physical therapy, you get what, $6 or $8, maybe $10 back. With blood flow restriction, that's all built into part of the exercise. Okay, so therapeutic exercise, therapeutic activity, and so it's a great added modality, but it's you know, it's a fraction of the cost of other types of modalities, and so easy to use. So so I'm going to let Susie take over, and I'm going to check this question out here, and we'll see if we can get to you, Megan, here in just a second.
Okay, awesome. We just have a last few slides, and then hopefully we can kick it open to some questions. You probably have a lot going through your head right now. And again, I don't blame you, because there's a lot of stuff we didn't hit today. There's so much detail with this modality, application, safety, devices, mechanisms, you name it. There's so much to go over. It's hard to do it in this period of time, but hopefully we were able to condense a decent amount to give you a much better overview of what the modality is and how successful it's been. So a lot of people, first question is it safe, right? There's approximately 300,000 KATSU sessions performed every day and no reports of complications. When we look at a national survey taken, there's about 6 cases maybe of DVT and 12,642 sessions undergoing 32,000 KATSU sessions. When you do that ratio out, it's about 0.00004% or something like that, very low. It's even lower than the amount of percentages of DVTs in the general public. So if I were to just take a survey in the United States of people with DVTs, you're going to have a higher percentage compared to what they found within those KATSU sessions. They're usually, if you want to give a reference point in a hospitalized population, there's usually about 1 in 100 have a DVT or so forth. There's only been 1 case of a pulmonary embolism. And again, that we can't even relate that to BFR. It just, they were doing BFR, but that could have came about some other way. And then there's only 1 case of rhabdo and about 32,000 KATSU sessions. So very, very safe, very, very effective. And let's get into, okay, well, who can and cannot use it? It's rare for children under the age of 5. There's really not much research out on there. The only absolute real contraindication here are for people who literally cannot exercise. So someone who has sickle cell disease, right? They aren't supposed to increase their blood flow anyway. So they would not be able to use this modality. Relative contraindications, which some of them sound silly, but it's true. During a medical emergency, address the emergency. If someone has a fever, sick, flu, rest, right? Pregnancy, now there really isn't much research out there on that. That's why it's a relative contraindication. It's not that it could be a negative thing at all. It's just there's not much research out there with pregnancy and BFR. While operating a vehicle, now don't place a band around a fresh wound. It kind of seems self-explanatory. Use the other 3 extremities. Don't place on a limb with lymphedema. Use the other 3 healthy extremities. don't place the band on with a vascular access, indwelling catheters, use the 3 other extremities, and then don't do exercises that really cause pain to a healing injury. Now, when you see here, the use of 3 other extremities, I'm going to use an example here that many people started to use BFR just on the injured arm or just on the injured leg. And that's really not what you want to do, even though you can get a benefit from that. What you should start to do is, for example, what I had the total knee replacement person do was right after they had the total knee done, yeah, they were, healing, the graft was healing, all of that. The upper extremities were fine. After they were home, 24 hours, felt great at home, I had them doing some light upper extremity work. Why would I have them do upper extremities when we really need to focus on the total knee that was just done? Well, because of that neural hormonal systemic response. So you're going to get, even though you're working, you're going to get that high metabolic fatigue within the upper extremities, but you're going to get that neural hormonal response of the growth hormone and IGF-1. That's systemic. That's going to surge throughout the whole body. And actually that knee is going to already start to benefit while you're resting it. So it's really important to use other 3 extremities that aren't involved if you can't apply a BFR band to the injured arm. So for example, let's say there was one stabilized with a humeral head fracture and you can't move that arm, right? It needs to stay stabilized. You need use the other 3 extremities, use the lower extremities, have them walk, have them alter blood flow patterns. That arm, that shoulder is still going to get those systemic benefits, even though it's not directly working. Another question I usually get is, okay, you're putting them around their arms and legs. How can my back muscles benefit? How can my core muscles benefit? Well, actually, even though you're not directly restricting them, you are indirectly restricting them. So even though you're restricting blood to the extremities, you are going to have a decrease in venous return back to the heart. So you're going to have a dramatic increase in heart rate as well. But that decrease in venous return, you're also going to be pumping a lessened amount of blood around the body as well. So indirectly, you will also be restricting those muscles, not directly, as well as all of the nutrients will go to also the muscles that are working. So even if you are doing a lot of back exercises, a lot of core exercises under, let's say, all 4 extremities BFR, will those get a benefit? Absolutely, because post-exercise, a lot of those nutrients go then to the area that was working. So I usually get that question quite often. We don't have, again, time today to go through every single device or anything, but you will notice that Paul and I really use this elastic pneumatic system, right? That, that's kind of more so over here. I've used a multitude of these, and I could add a few more pictures of what I've used as well. Really what you want in a device is something that's elastic and pneumatic. Something that's rigid, such as a blood pressure cuff or a cuff system, not only is it uncomfortable, you have a very narrow very narrow window of operation to be successful. You want something that able to flex and extend with the extremities and have a decrease in risk of occlusion. And there are some bands that are out there that actually have that.
Hey, Susie, any chance I could jump in?
Yep, go for it.
I think this might be a good time to answer. Somebody asked this question here. How do we know how much to tighten the bands? Is there, for the appropriate amount of blood flow restriction? And so here's the fearful word, is restriction. Everybody talks about blood flow restriction. That's when people get nervous, is they think this can't be a good thing. That's why Susie and I truly believe that it should be termed something else. But to answer that question, with the system that we're using, what you do is if you have a certain color band, you go to basically a cheat sheet, and with a red, it's like 200 millimeters of mercury. So you take your pump and you pump it up basically like this. So you pump it up till you get to your 200 millimeters of mercury. And then you put the patient through their paces. And basically you're looking for 30 repetitions with a 30-second rest. Now, how do we know that pressure is just right? Well, we always start at the lowest, which is what the cheat sheet gives us. But if they're getting to 30 repetitions, they really don't feel like they're too fatigued, then what we do is we up them 25 to 50 millimeters of mercury for the next time they come in when they do it. Basically, what we're looking for is that fatigue to happen, where they're having trouble between rep 25 and 30, and they're really kind of failing. And so that patient that I had yesterday with the lateral patellar compression syndrome, she was doing modified knee extensions with a 2.5-pound weight, and she could just barely get to 25, 26. And that's what we want, is we want that failure. and then she gets her 30-second rest, and then she starts over again. And that's where we kind of make those adjustments. And the other thing you should know is that some systems force you to use a Doppler. So you can use a Doppler here or a Doppler here to see how much flow you have going. Problem is you're tied to a machine that is tied to a wall, and you're very restricted, where I can set people up with a band like this and they can take off throughout the clinic. You know, you can go for a bike ride. I mean, Mark Wahlberg, on his off days when he's not doing heavy lifting, he uses blood flow restriction, and he'll go for a bike ride, and or he'll do some, you know, lightweight, high repetition work just so he doesn't get so much of that muscle damage on his rest days. So you modify it by feel and what the patient is able to accomplish. And so that's really easy to do. So that was a great question. And the other question was, can you train the patient to do BFR at home the same way? And Susie and I have had some pretty lengthy conversations about this. There are a lot of practitioners out there who are trying to say, here's a little 1 hour talk on BFR. Go ahead, you're ready to go. You're ready to roll. I'll tell you, I learned a lot in the certification. I would never have felt comfortable setting up a patient without having been certified and used it myself and made sure my instructor, like you have to do it in front of the instructor to make sure that you're using it appropriately. And so, but yes, like with Emily, the gal who had the chondral lesion and she had the replacement, you know, we felt comfortable with her using it in here often enough. She understood how to use it. We actually watched her apply it to herself in here, and then she bought a set for herself, and then we gave her a home exercise program with all of the blood flow restriction, you know, exercises on it. So she was able to continue doing that at home. And then, you know, she calls me or texts me whenever she has a question, and we make modifications as we go. So that was another question that we had. So yes, patients can do it, but you know, I like them to learn with us first.
Paul, I'm going to hop in too and piggyback on top of that first question with regards to the pressures and whatnot. That is something we go in depth over, and that's the point I was trying to make with a rigid versus an elastic pneumatic system. You want something that's measurable, but you also want something that's elastic and has give to it. With bands where you don't have to be tethered, again, like Paul said, you can more focus on biomechanics and sport-specific movements versus kind of walking around with a machine type of thing. And also, I'm going to share in the notes with all of you an example of a Doppler video of using a rigid cuff versus an elastic band. Now, some of the systems that I finally use and what I apply to my clients and work with patients in conjunction with PT as well as Paul is that this type of band system, you can actually pump up on the system to 500 millimeters of mercury, and you're not going to occlude that brachial artery or the femoral artery. Now, where if I used a rigid system, I'm actually going to probably occlude around maybe 120, 130 just before systolic blood pressure comes in. So you have to back it off a little, very narrow limits. It's uncomfortable. It's rigid. There's no give to it. So with an elastic pneumatic system, what I like to say, and I use with clients and patients and all of that, is it's dummy proof. So I feel confident, and after teaching someone the modality, teaching them how to use it, they really can't mess it up. And that makes me feel comfortable as a practitioner that they're safe under BFR. And that's something we really go in depth on. During the certification, I have you guys do your limb occlusion pressure, find your radial pulse, find your limb occlusion pressure, and we do exercises with the rigid systems, and we use it then with elastic systems, and we apply, and we go through all of this much more in depth. So it's important for patient safety, education, application, optimum efficiency and results, really helps decrease skepticism. And I know Paul has spoken to that, and he can speak to that for sure after getting properly trained here. And then of course it increases confidence with application. If anyone is interested, this is what is included in a certification. We really go in depth on everything we've talked about today, much more so. And then we do a lot of active sessions where you get to use the systems, you get to use BFR. Now, one last point I'd like to make, and then I'm going to kick it to Paul if he has some questions out there, is the fact that why I decided to finally hook up with this system, and why do I use this elastic pneumatic system? Safety and efficacy are number one. But then I was doing a lot of work in New England with BFR, and like everyone else, as a researcher, as a practitioner, I'm a little bit skeptical on any new thing that comes out, any new device. Well, the owner of this B Strong Systems, or the bands, actually, the two owners actually called me. He's the sports med physician that designed these, and actually NASA designed this technology for you to not occlude, which is actually very interesting, and we go over that. But Dr. Gunderson called me out and said, why don't you come work with me in the Olympic Training Center, the ski snowboard center in Park City, Utah. And I did for the last half of a week. So I went out to Utah and I worked with him for a few days at the Olympic Training Center. And, you know, we went through the whole Doppler thing. We went through all of that. And Dr. Gunderson himself trained under Dr. Sato in Japan and is a Katsu master himself, and helped design these for practitioners for this purpose. So the reason I put my weight onto this first and foremost was that he was a Katsu master under the guru of BFR himself. So if there's any sort of weight to that, hopefully that does kind of hold some weight to everyone. It did for me. And then once I was practicing with it, compared it with every other system out there, it's definitely the easiest to use and the safest to use with patients and clients. So Paul, if you want to kick it, I'm going to escape this.
So we had another question, and it was, you know, has this shown any benefit with, you know, fall reduction risk and those types of programs? And it's interesting, Susie and I were talking to the folks from MedCore about this the other day, and yes, you know, you can definitely use it with an older elderly population. And there are some studies that have shown a decrease in osteoporosis while using the blood flow restriction bands. So they took a study group and they had them on a treadmill. I believe it was 8 minutes twice a day. They had a group with BFR on and a group without, and there was an improvement in bone density with these folks. And if we're seeing an improvement with blood flow, blood pressure, then that is another benefit. Again, it's a safe modality, and especially with these elderly patients who cannot really do heavy, you know, training or heavy loads, then those folks can just walk with them on, or they can do very light, you know, weights, you know, even if it's a pound or just body weight. Like when I went through the training with Susie, it was just incredible. I started, you know, doing militaries. We were doing upper extremity. And so I was doing militaries with 10 pounds. And I basically got done. I had to do my third set with 0 weight because I just couldn't continue because it was, you know, with the really lightweight, I got such a great benefit out of it. So definitely, you know, one of those things that we're looking at. And, oh, and the other thing, Susie, did you, do you want me to talk about the Doppler while we're at it?
I sent it right into the link. So that's what I was talking to you guys all about a little bit before. It shows a good example of a rigid cuff versus the elastic pneumatic cuff, and how it's really impossible to occlude with this elastic pneumatic system, which is good because we want that restriction instead. So I just shared that YouTube link with you all to go take a look at on your own time. And then also shared, I know we're running out of time here. We could talk all day. I know I could on this, and gave our contacts there. So feel free to email us anytime with any more questions that you have, or if you would like some references, happy to send those as well.
Any other questions? Let me see, Susie, do you want to field the next question that came up?
Yep, so BFR absolutely translated for normal hypertrophy. Actually, Katsu training was invented for bodybuilding itself, was actually not even for rehabilitation. So blood flow restriction, it's just actually become more popular in rehabilitation. It was originally made for strength training and increase in hypertrophy and protein synthesis. So yes to number one. And then is it possible to completely replace traditional for muscle hypertrophy? Absolutely. Now that's a different question. You can absolutely replace it completely. My husband and I use BFR and we take it on the road. So if we're in the hotel room, we don't need to go find a gym. We can take it on the beach, walk with it, do whatever, still get a good workout in and not miss anything. Now you can completely replace it for hypertrophy purposes. However, it all depends on the type of athlete too. If someone's a powerlifting athlete or a power sport athlete, you use it on what's called an icing on the cake type of modality. You would use it at the end of a workout or on your off days doing something very low intensity. Because if the goal for you is to lift a heavy bar over your head, you still got to practice lifting a heavy bar over your head. So it all depends on what you're using it for and what the sport or what the goal is.
Any other questions? Well, thank you all so much for joining with us today. It's a lot of information in a short amount of time. Susie and I are always willing to, answer questions. So feel free to get in touch with us, and we can give this talk to classes if need be, or other groups of people.